Good afternoon, everybody. Thanks for joining us today in our cardiovascular grand rounds. Welcome, Dr. Mittal, and thank you for joining us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you to our moderator for this event, Dr. Luis Carlos Sáenz, Director of the International Arrhythmia Center, and Dr. Maria Juliana Rodriguez, Chief of Cardiac Failure. Welcome, and thank you for moderating this event.
Buenas tardes a todos y muchas gracias por su conexión y asistencia. Mi nombre es Luis Carlos Sáenz y estaré junto a la doctora María Juliana Rodríguez compartiendo la moderación de esta actividad. Les recomendamos que al conectarse a esta conferencia, les recordamos, disculpen, que al conectarse a esta conferencia ustedes autorizan el tratamiento de sus datos personales, los cuales serán hechos de acuerdo a la ley 1581 de 2012 y nuestra política de datos personales, la cual puede consultar en www.cardioinfantil.org. El chat de preguntas se encuentra habilitado en la barra de participantes y les agradecemos dejar allí sus inquietudes y preguntas, las cuales resolveremos al final de la sesión. Enviamos un agradecimiento muy especial a Abbott por vincularse como patrocinador exclusivo de esta actividad. Y tenemos hoy el honor de contar con un líder de opinión de gran reconocimiento mundial, quien nos hablará de monitoreo remoto de dispositivos cardíacos implantables en pacientes con falla cardíaca. A continuación, la doctora María Juliana Rodríguez hará la introducción del doctor Mittal. María Juliana, bienvenida.
Muchas gracias. Como les mencionaba el doctor, hoy tenemos el honor de contar con la participación como expositor del doctor Suneet Mittal con la conferencia Remote Monitoring of Cardiac Implantable Electronic Devices in Heart Failure Patients. His training includes BA and Medical School at Boston University, internship and internal medicine residency at the Hospital of the University of Pennsylvania, Cardiovascular Diseases Fellowship at the Hospital of the University of Pennsylvania, Clinical Cardiac Electrophysiology Fellowship at the New York Presbyterian Hospital, Weill Cornell Medical Center. Dr. Mittal is board certified in cardiovascular disease and clinical cardiac electrophysiology. He is currently the director of the Electrophysiology Laboratory and associate chief of cardiology at the Valley Hospital in Richwood, New Jersey. He also served on the board of trustees of Valley Medical Group. And also he is a key opinion leader in the field and the PI of many trials of this topic. Welcome, Dr. Suneet Mittal.
Thank you very much for that kind introduction. It's a pleasure to be here with you today to talk about a topic area that's been very dear to my heart, which is remote monitoring of patients with implantable devices. And although the topic is to focus on heart failure, I'm going to take some time and just talk about the overall topic in general. And again, thank you very much for joining me today. So today I have 4 objectives. First, we'll review the currently available scientific data for and against remote monitoring. We'll assess the United States landscape of remote monitoring. I'll tell you a little bit about our hospital's remote monitoring program, and then hopefully we'll have an open discussion to highlight some of the unique challenges that would be present in your geography, which could be slightly different from what we are experiencing. So I was telling Dr. Luis that I just got back from Heart Rhythm Society meetings last week. And really, one of the most noticeable changes is this interest in remote patient monitoring. There's so many companies now in the space. And remote monitoring in general is very much a common theme in the lay press. But I think cardiologists often forget that we are not new to remote monitoring. In fact, if you think about it, trans-telephonic monitoring of devices was now 50 years in development, and we've been remotely monitoring these devices for some period of time. The thing that really changed was that after doing it the same way for 30 to 35 years, Finally, in 2002, we had the ability to do what's called remote follow-up, the ability to move beyond just transtelephonic monitoring, but to get more information from devices. And in 2005, the game changed completely with the advent of completely wireless devices, which now gave us a very robust look at all elements that are contained within an implantable device. So when it comes to remote monitoring, I think it's appropriate, given the ongoing Olympics, to really think about the 5 things that, at least in the United States, have really spurred remote monitoring. And the first one that I want to get right off the table is reimbursement. We are uniquely benefited in the United States that for many years, we've had a very robust reimbursement policy for remote monitoring. And at its most simple level, we get paid exactly the same whether we do a device check of a patient in the office or whether we do it remotely from their home. And that kind of reimbursement has really helped spur the development of this field in the last 20 years. The second thing that we have is in 2015, we have a Heart Rhythm Society expert consensus statement document that very much advocates remote monitoring in comparison to the historical way of managing these patients, which is bringing them from their home into the office on some calendar-based schedule. In fact, I had the privilege of being a writer for this guideline document, and the most important finding from this document is the statement that's highlighted, and that is all patients with an implantable device should be offered remote monitoring as part of the standard follow-up management strategy. It has the highest recommendation, Class 1 level of evidence A. Here we see what the Heart Rhythm Society recommends is that once the patient has had some sort of a wound check, they're evaluated on a monthly level if they have heart failure, quarterly level, otherwise, and then only come into the office on a once annual basis. Now I want to spend some time covering the scientific data which makes remote monitoring possible. First, we know that remote monitoring has a number of propositions. You can get device-related, lead-related, and arrhythmia-related findings, and ultimately there's a tremendous number of interest in determining if heart failure-related variables can also be determined. Very early on, studies started to show that the old way we did it was not as good as the new way. Here's a study from 2009 where they took 900 pacemaker patients, randomized them to transtelephonic monitoring or remote follow-up. You see on the right, very little yield with transtelephonic monitoring and a very high yield with remote follow-up, because you could get the stored diagnostics that were not possible in a transtelephonic system. We also learned that there were a lot of patients having non-sustained ventricular tachycardia and atrial fibrillation at home. Afterwards, Dr. Crossley did this study where they looked to see the impact of remote monitoring versus in-office follow-up. You see that when there's a critical arrhythmic event, you can get that event in your box almost 5 times earlier than waiting for the patient to come into the office. And once you act on these arrhythmias, then you can potentially improve the outcomes of these patients. This was the study that really finally brought this into scope. This is Dr. Neeraj Verma's TRUST study, where he randomized patients with an implantable device capable of wireless follow-up to either home monitoring shown in the lighter color and standard in-office monitoring shown in the darker color. You see that home monitoring leads to more adherence with follow-up of devices, leads to earlier detection of arrhythmias like ventricular arrhythmias, SVT, atrial fibrillation. It decreases the number of scheduled visits and most importantly, does not come with any sacrifice in the safety profile of following these patients. This data has been looked at for pacemaker patients. Here's a variety of studies. The COMPASS study showing that remotely monitoring pacemaker patients resulted in a 2/3 reduction in the likelihood that a patient would be hospitalized for an atrial arrhythmia or a stroke. You can maximize battery longevity as shown on the right, and you lose many fewer patients to follow up when they're being remotely monitored. Last year, Dr. Watanabe and colleagues published this study called the Japanese at-home study, where they looked at nearly 1,300 pacemaker patients, and they were randomized to either remote follow-up or in-office follow-up every 6 months. Patients were followed for 2 years, and again, the two strategies are non-inferior with respect to the composite endpoint shown alone. So not only can you get the information faster, does not come at any risk to the patient. How about defibrillators? Well, the data are very similar here. Here's the ECOST study looking at in-office follow-up shown in blue versus remote follow-up shown in the orange color. And in summary, what the study showed is that when you're home monitored, there's less shocks, less inappropriate shocks, improved battery longevity, and there's a much lesser need to show up into the office for routine in-office checks. So it really does appear that for the most part, it is a win-win proposition for our patients. Now, how about the impact on a harder endpoint like mortality? This is a study that I had the privilege of being involved in. This was a study where we evaluated almost 300,000 patients in the United States who were implanted with a St. Jude pacemaker or defibrillator capable of remote monitoring. The first thing I want to show you is that even in the US, over half the patients were never enrolled in remote monitoring. Of the other half that were enrolled in remote monitoring, about half were using it reliably, more than 70% of the time in a given year, and the other half were using it, but not as high as 70%. And what we wanted to determine is there a relationship between remote monitoring use and overall mortality in this group of patients? These data are shown here. What you see is that when you look at the group of patients who are using remote monitoring to a high degree, shown in green, they have double the survival of patients who are not using remote monitoring, shown in red. And there appears to be a dose response curve in that the ones who are using it more often than not had a higher mortality. And even if you are using it a little bit of the time as shown in blue, you are still living longer than those patients who are never using it at all. Importantly, these relationships held true irrespective of whether we looked at patients being implanted with a pacemaker, CRT pacer, defibrillator, or CRT device. How about the time to enrollment? These are data that really surprised us. So here's a group of patients, 100,000, all of whom were enrolled in remote monitoring. The only difference is the group in purple were enrolled in remote monitoring within 90 days of implant, and the group in red were implanted over 90 days after implant, but within the first year. When you look at survival on the right, there's an 18% improved survival over follow-up when remote monitoring is instituted early. So these days, we start the remote monitoring process right at the time of implant. And in fact, the guidelines say that it may be beneficial to initiate remote monitoring within 2 weeks following a device implant. This has a class 2A recommendation with a level of evidence C. Now, prospective studies have confirmed the mortality benefit. On the left, you see the in-time study, patients implanted with a defibrillator or CRT device, randomized to home monitoring in blue versus in-office follow-up in green. there was a 5% absolute difference in survival at the end of follow-up. And I would ask you, there are not many things we do in medicine that lead to a 5% absolute improvement in survival within 1 to 2 years of follow-up. On the right, you see the TrueCoin study, which is a composite of several studies showing, again, the beneficial impact of remote monitoring on all-cause mortality in this heart failure type of population. Now, these days, what's also important in your healthcare system and my healthcare system is to make sure that this translates into dollars saved. To look at this phenomenon, we looked at 100,000 patients implanted with a device. Again, only a third were on remote monitoring. The other 2/3 were not. What we saw was that those who are in remote monitoring had an 18% lower likelihood of being hospitalized, which translated into 3 less days in the hospital. And this translates into a substantial 30% savings in healthcare utilization costs, which is an impressive 45% in patients with devices like CRT devices that are being used for heart failure. And look at these data. We estimated that for every 100,000 patient years of remote monitoring in the United States, there'd be 10,000 fewer hospitalizations, 120,000 fewer days in the hospital, and our healthcare system would save almost $400 million in payments to the hospital by being more actionable with respect to our patients. So we feel that remote monitoring can really impact healthcare utilization as well. Now, I want to be fair that not all studies have demonstrated a benefit, and we can discuss why that may be. Here's the MoreCare study, a much smaller study, less than 1,000 patients, prospectively enrolled, randomized. These were all de novo CRTD patients. The primary endpoint was a composite of mortality and device-related or cardiovascular hospitalizations. And you see that the Kaplan-Meier curves are almost superimposed. The randomization scheme you see, in-office follow-up every 4 months versus in-office alternating with remote follow-up. And you see that at a minimum, it substantially reduced the unnecessary visits in the office, but it did not translate into a difference in heart outcome. Similarly, in the remote monitoring in a study where remote monitoring was coupled with measurements of blood pressure and weight, again, no significant difference in mortality, all-cause rehospitalization, cardiovascular rehospitalization, or heart failure rehospitalization. And so the jury is still out as to why certain studies are positive and others are not able to demonstrate this difference. Now, one of the reasons why things may have been negative in these studies is maybe relying on blood pressure and weight is just very rudimentary. Here's an approach as using a multi-parametric sensor approach that is available in current Boston Scientific devices, in the US sold as something called Heart Failure Logic. This algorithm integrates heart sounds, respiration information, transthoracic impedance, heart rate and activity, and with a reasonably high sensitivity and specificity, could anticipate heart failure decompensation almost a month in advance, which gives us some reason to be more optimistic. Another variable that I like to use is trying to look at the percentage of LV pacing in these individuals and being alerted to when this is dropping off. Now, historically, we've relied on the counter that shows how often they're pacing. And obviously, if you get a low number, then you have an issue. But what I've been interested in is trying to show that if you get a high percentage, does not always mean that the patients are actually effectively capturing. In fact, the Medtronic effective CRT algorithm works to differentiate the percentage CRT pacing from effective LV capture. And what you see is that there are some patients who have a high degree of percentage CRT pacing, but a very low percentage of effective LV capture. Why is that? that occurs because of things that cause fusion and pseudo-fusion like PVCs, atrial fibrillation, latency, loss of threshold from the LV lead. And this algorithm, by looking at the electrogram characteristics from the LV cathode to RV electrogram, can do a very good job of separating effective LV capture from just a high pacing number that is not effectively capturing. So this is another alert that we built in to our remote monitoring center. So if I had to summarize, there are certain advantages of remote monitoring of CRT devices, for example. We can get information about the battery. We can get information about the lead. We can get information about the percentage of LV pacing and how effective that is. We can get information about arrhythmias and heart failure exacerbation. And each of these can then translate into some troubleshooting feature that can ultimately improve the outcomes of our patients and importantly, keep them from necessarily coming into the hospital when they're further ill. Now, there is a tremendous investment that's currently ongoing in this space. These include things about utilizing the smartphone, which is now ubiquitous worldwide, and software developments, both in the artificial intelligence space, as well as the electronic medical record space. And so let's talk a little bit about why this is very important that we get these types of advancements. So it turns out that remote monitoring is good as a concept, but it is very hard to implement in actual practice. So I mentioned earlier that the TRUST study was the largest study done in this space and really gave us insight into the value proposition of remote monitoring. But what's incredible is that this study included 105 hospitals with less than 1,500 patients. Most hospitals enrolled less than 10 patients. The largest site only enrolled 88 patients. Many of us are following 3,000, 4,000, and 5,000 patients in the clinic. And so the question is, can we scale remote monitoring in a way that's even viable in day-to-day clinical practice? In the United States, we already know that many hospitals cannot. In fact, in this study, we were really surprised to see that the single biggest determinant of whether a patient gets enrolled in remote monitoring following ICD implant in the US is simply what hospital the ICD implant occurred in. Certain hospitals enroll nobody in remote monitoring. Other hospitals enroll everybody in remote monitoring, and some are more variable. So there are institutional specific variables that are determining who should or should not get remote monitoring. Why is that? Well, it's because when you embark on remote monitoring, there's just so many challenges. And one of the challenges is, how do we ensure that patients are connected and even transmitting data from their device? Many studies come from Europe, where they only use the Biotronic home monitoring system with different requirements for communication. So it's been unclear whether the data are applicable to Medtronic, Abbott, Boston Scientific. And in fact, in the United States, we've learned that over half the remote transmissions are missed due to non-compliance, and it takes hours every day just to get these patients rescheduled, so a very labor-intensive process. This was shown 10 years ago in this study, 2,000 patients with a defibrillator or CRT device. About a quarter of them had a clinical alert. The first thing was that in half of them, the alert never even made it to the doctor because the alert was programmed off, or the alert had happened, some other alert had happened before and no one reset the alert, so they were all missed. Even when the alert came, in half of the people, the alert never got transmitted to CareLink because there was just some data communication error. And overall, only 30% of all alerts ever made it to the server for the doctor's review. And there's so many reasons why patients come online, but this is a major issue that 70% of patients, the alert never even made it to the doctor because of a variety of technological limitations. Now, what can change that? I believe the smartphone has the greatest opportunity to change that. From what I can see now, worldwide, virtually everyone today, irrespective of socioeconomic status, seems to have one of these supercomputers in their pocket. You know, The Economist had estimated that very soon, 80% of the world population will have such a phone. Today, everyone is on their phone at all times. And now the devices are coming around, which essentially use Bluetooth technology to transmit the data from the device onto central servers. And I think this will be very helpful because everyone has their phone, that it's very unlikely you're going to get disconnected from these servers. And it should actually facilitate data transfer from the devices into the servers where we can review this information. And the first set of publications showing the utility of these types of systems are definitely on the way. And I think this will become the new standard of care. Here's another reason that I'm sure you've all wrestled with. The workflow of remote monitoring is very complicated. On the left, I show you all the things that go into remote monitoring. You have to educate the patient, you have to enroll them, you have to schedule them, you have to monitor the websites, you have to communicate the information, dismiss the downloads, reschedule people, maybe get the information into an EMR system, then a doctor has to look at it, you have to bill maybe for it, communicate. And all of these tasks are built with all doctors, nurses, industry representatives, and it's a very fragmented and disjointed process. At least in the United States, brand new companies are emerging in the space that all they do is serve as a conduit between our patients and us. So we only get the information that's most actionable, and we don't have a lot of junk information. Now, we know we get a lot of junk information because there are devices like loop recorders that are producing a lot of information. So at least in the US, loop recorders are used very commonly for syncope, AF management, cryptogenic stroke populations. They transmit data on a daily basis, so they create a data deluge like we've never seen. And look at the positive predictive value of AF detections, pretty bad, like 20%, 30, 40%, which means that 2/3 of all the episodes are false positive. This is particularly a problem when the episodes are less than an hour in duration. And this is becoming a huge chunk of time commitment for us. So I believe that for this kind of stuff, the greatest value is going to occur in the use of artificial intelligence to weed out the junk from the real stuff. We recently published this paper in JACC EP, where we evaluated our implantable loop recorder clinic, and we took the data for AF and we ran it through a deep neural network. And we could see that the neural network was very, very good at eliminating noise, APCs, VPCs, sinus arrhythmia, a false detection of pauses, all the things that cause all of these false positive AF episodes, and we could decrease the false positives by 2/3. And I think as AI gets better and better, we'll be happy about that because we'll get information that's more actionable as opposed to all of this information that we have to spend time to look at that we can't do anything about. So in the final few minutes that I have, the other big issue is cybersecurity, because cybersecurity is becoming a big issue, and cybersecurity has to be addressed, especially we start to evolve in an era of remotely programming these devices. I'm sure at sophisticated centers like yourself, patients travel miles and miles, if not from different countries, to see you. And how great would it be if you could remotely program their devices rather than having them make this journey to your hospital. But to be able to do that, we have to solve the cybersecurity issue. There's so many reports in publications like the New York Times and others where the people are frightened by reports like a heart device is found vulnerable to hacker attacks, or pacemakers and implantable defibrillators, software radio attacks, and zero power defenses, where these research scientists can show how easy it is to really hack into the devices that we're implanting today. And all of you know, if you've ever used a programmer, how unsecure it is. Doesn't track any passwords, doesn't keep track of who's reprogramming when or what. And so all of these things have to be improved on if we're really going to get to the bottom of the cybersecurity issue. This was really well laid out in this review article by Dr. Baranchuk and colleagues, where it talks about hackers, the government, manufacturers, physicians, and professional societies, and the roles that we all play in trying to become, to make sure that these systems are way more cyber secure than they are today. And I think this is an area that we're going to see a lot of development in the future. So I want to end by just reviewing with you what we do at Valley. So at Valley, we have a several-step process. Prior to implanting of a device, we teach all the patients the utility of what it means to follow up their device. We tell them the pros and cons of in-office versus remote follow-up. We outline how frequently we want to follow them, daily for loop recorders, monthly for heart failure patients, quarterly for standard pacemaker and defibrillator patients. We help them to understand the differences between remote monitoring and remote interrogation. We help them understand what our role is in this process, and if they're being managed by heart failure, EP, general cardiology, who's responsible for what. We try to determine their suitability for remote monitoring. Are they someone who can operate a smartphone? Do they need a bedside communicator, etc.? And we are also trying to determine how do we get patients access to their own data, which is a bigger and bigger requirement and need expressed by our patients. We have a standard brochure that we have developed to give this to our patients, to help them understand why we are recommending remote monitoring. That it's not because we don't want to see them in the office, but because we feel that they will get better care and better outcomes if they're enrolled in a comprehensive remote monitoring program. Then we make sure that the patient's enrolled in remote monitoring. We try to give the patient the remote monitor at the time they're being discharged after the implant. And all patients come to see us 7 to 10 days after the implant for a wound check. And we make sure at that time that remote monitoring has been successfully instituted, the data are coming into our office, and everything else is good with their systems. And finally, again, on a daily basis, there's a lot of work that needs to be done. You have to make sure that you identify patients that are disconnected. And as I mentioned to you, you have to review alerts daily for ILRs, weekly from pressure sensors, monthly from loop recorders and heart failure patients, and quarterly from pacemaker and defibrillator patients. And there's some strategies that can be pursued to standardize these alerts to try to maximize the efficiency of the information that you get back. And finally, at least in the United States, we are responsible for aggregating a summary report and communicating this information back to the patient's healthcare providers. This is still a very labor-intensive job, and we're all searching for IT solutions to try to make that aspect a little bit easier. The final thing I'll tell you is, as I mentioned to you at HRS this year, there is a growing involvement of companies in the remote monitoring space. As a result, the Heart Rhythm Society has committed to taking the lead in the area of digital health. And in December, we will be holding our first annual HRX conference. It's devoted to all things related to health tech, digital health, remote monitoring. The meeting will be held in San Diego, but viewable completely online in a virtual platform. And for those of you that are interested, I encourage you to go to the website shown below, and it would be great to see you register for this meeting and join us at this meeting so that you can actually share with the developers and builders of many of these remote monitoring platforms the kinds of solutions you need to be able to best manage the patients you're managing in your local geography. With that, I'm going to stop. I want to thank you very much for the opportunity, your time and attention. And Maria, Luis, I'm happy to answer whatever questions you or your audience may have.
Okay, thank you, Doctor, for your excellent presentations. We are going to start with the questions. I have one. I mean, you just show us the shocking evidence we have with the result of the remote monitoring, but how to implement it in an easily way in our country, you know, because probably we have the same troubles you had at first, but in an easy way, what are your advices?
Yep. So I think the biggest challenge is that the doctor-patient relationship is very strong for people. And historically, we grew up where when you saw the doctor, that's when medical care was being delivered. And now for many patients, it's hard to understand how care could be delivered remotely. So what I tell my patients is, there was a time when I drove my car that every 3 months I would check the tire pressure. And sometimes the tire pressure would be low, but I had no idea when it became low and how much damage I did to my tire while I was driving with the bad tire pressure. Today, I never check the tire pressure until the light in my car goes on, and then I say, okay, there's a problem, and I go check. And I tell patients that devices are the exact same thing. No, it makes no sense to miss all of the information that's contained in these devices, that we still continue to follow our patients, but to maximize what's happened with them, that we have to be able to rely on all of the information that's in these devices and alert ourselves and them when there's a problem. And it's a process. It takes time for patients to get used to it. Older patients have a more difficult time adjusting than younger patients who are more tech savvy, but little by little, this is inevitable. This is how we will have to manage patients.
Thank you, Doctor. We have another question from one of our colleagues, Dr. Medina. A concern that patients may have is cybersecurity, particularly with insurance, companies that can use the data for prohibiting or limiting coverage when patients change their residency or want to switch companies. How do you approach this concern with patients?
So what we tell patients is that their data, of course, is on a server that the vendor maintains and us, but that their insurance companies cannot get that information whatsoever. It's completely locked in. In the future, I think we will have another change in this, which is I think patients will have the ability to give people access to their data. And only when they have given access to their data will other providers be given access. So today, maybe the patient is implanted at your hospital, and maybe Maria, Luis, you both can see the data because the patient was implanted in your hospital. I suspect in the future, what will happen is unless the patient gave you, Maria, and you, Luis, individual rights to access that data, you will not be able to see the data. And I think that's an important way to generate trust on the part of the patients and make it more secure than it is now.
Next one. What are your thoughts about cardiomems in the heart failure field?
We think I think that one of the things that we often hear is that there's no proven therapy for diastolic heart failure. And I always say that that's not correct. We actually have a proven therapy, that PA pressure guided management of a diastolic heart failure patient has been shown to improve outcomes. So I think CardioMEMS is a very, or PA pressure sensors, because as you know, additional companies are now doing clinical trials of more sophisticated technology, maybe a better user interface. But I think a PA pressure sensor definitely has a role, as do other emerging technologies like intraatrial shunt devices and a whole slew of things that are being worked on. So we're very proactive in recommending these sensors to the appropriate patients in consultation with heart failure colleagues, because I feel that when you're making a decision for something like a PA pressure sensor, it's very important to have your heart failure colleagues involved in that discussion.
Thank you very much. We have another question from our college. How soon, speaking of artificial intelligence, how soon do you think it will impact practice?
So that's a great question, because one of the reasons I did my study was I was frustrated because every day on television, I hear AI, AI, AI. And I'm like, well, when is it going to help me, in any way? And so the study we did was designed to see, could it help us in any way today? And at Heart Rhythm Society meeting last week, we were pleased to see that Medtronic has just released information that their loop recorders in a few months will take advantage of a similar AI level technology, which they have shown can decrease false positive rates in loop recorders by 75%. So I think that is going to now open the gates to use that technology for other devices and other indications, but it is going to help us manage our data, I believe, like never before. So it's now right around the corner for our daily use.
Okay, thank you, Doctor. I don't know, I don't have any other question. I don't know if Dr. Sainz have, okay, thank you.
Yeah, I have some questions. Well, thank you very much, Dr. Mittal, for a great talk. We really learned very important messages and points from your presentation about remote monitoring in heart failure patients with implantable devices. So you showed us a lot of benefits of remote monitoring in those patients, right? But it is contradictory that we saw that the adoption of this technology is relatively slow, not just in our region, but also in the States, for example, as you showed us in some slides. Despite of you showed that offering remote monitoring to a patient implanted with a device with this capability is a class 1 recommendation. So it is really contradictory, this situation, right? Because from the guidelines, when we saw a class 1 recommendation, it's like not good practice, clinical practice, doing something different. So how can you explain that?
I think that is an amazingly good question. And one of the things that I want to really stress to you is that often what we hear is that, well, it's poorly adopted in our country because we don't have reimbursement for it. And I would caution you that that is not the right answer, because in the United States, we had reimbursement for it. And even with reimbursement, the adoption is very low. So it's an important point, because this has nothing to do with reimbursement. What it has to do is workflow. So think about how busy you are on a daily basis. I'm sure your OPD clinics are full day and night. You're coming in, there's no shortage of patients. Every day you turn on the lights and hundreds of patients are showing up in your office, right? And you say, okay, if I do remote monitoring, how exactly am I going to do this remote monitoring when I already have hospital responsibilities and clinics are full? So the problem we have is nobody has worked out the perfect workflow system to do that. And that is what's impacting the adoption of this technology. And the reason no one's worked on the workflow is because we think we'll just keep doing what we do every day and add an hour or two in the day to do remote monitoring. Obviously, none of us have an hour or two a day. So you have to start and redesign the way the care is delivered in your center. You have to give people time to look at the remote monitoring, just like they're looking at a patient in front of them. And you have to sit down with hospital administration, your nurses, your colleagues, and redesign the entire way that information flows. And then you get ahead of the game and maximize the utility of remote monitoring.
Right. Thank you very much. So another important comment is that the benefits of remote monitoring is not just based on the technology itself, right? Because the technology show us alerts about something is happening probably, but the benefit will be complete when you become actionable. You set this alert. So you have to start some workflows to do something, right?
Yes. So one of the big mistakes that people make is that when they're new to this and they are implanting a device, they just turn all the alerts on because they are so scared that they'll miss an alert, right? So they turn everything on. And that is a big mistake. So you have to spend some time in generating workflows and optimal alert protocols so that you can kind of find the sweet spot of sensitivity and specificity in your patients, recognizing that you will always err towards higher sensitivity. You don't want to miss any, alerts. And then hopefully, although that will compromise specificity, that AI can help further reduce the false positives. That's how I see this going. But you cannot just turn all the alerts on, otherwise you will drown in these alerts.
Absolutely. So my question is, obviously, when you get an alert, you have to connect teams, right? Because, for example, you can get information about the patient is started to present overload, right? For example, a fluid, etc. So you have to connect with the heart failure team, for example, right?
Correct.
So how to guarantee this kind of connection? How to promote and to keep this connection in harmony,
Yes.
in an efficient way?
Yep. So what we do is every morning when the alerts come in, we triage the alerts. So is it an AFib type of alert? It goes to the electrophysiologist. If it's a Optival heart failure logic, percentage LV pacing, it goes to a nurse practitioner who works with the heart failure team and EP together, and we triage it towards the heart failure department. But you need somebody who's going to be a bridge between electrophysiology and heart failure to try to get that alert to the person who has the best ability to manage that alert. So it's a reminder, again, that care needs to be delivered in teams, not as individual providers.
Okay. There is another question from one of our colleagues is, do you follow up remotely Parkinson patient devices, Dr. Mittal?
Yeah. So the answer to that is not yet. And that has been one of the limitations of remote monitoring since we've adopted HIS bundle and left bundle pacing. Those systems are just not robust enough to be able to rely on remote monitoring. And in fact, one of the problems we have in using those technologies routinely is that it basically negates the value proposition of remote monitoring. So the companies are going to have to become more sophisticated in being able to help us determine, how well pacing is occurring by giving us more ECG-based templates within those devices. Currently, that's a big limitation, and a similar issue for leadless pacing. It's not well suited to remote monitoring just yet.
Okay. You showed us also that maybe a way to optimize the specificity, right, of the alerts provided by the devices in remote monitoring is combining information, right? Not just alerts for long impedance, for example, but adding another information. But now is, as you mentioned, multi-parametric information provided by some brands of those devices. But maybe another way is connecting the patient, right? Asking for how is changing the weight, his weight, for example, or symptoms, etc. So are you doing that? Do you include in your workflows contacting the patient, trying to get more clinical information to decide the specificity of the
So you're 100% right, but unfortunately the systems don't exist yet, because the ideal system would combine the devices, the information from the implantable devices with the data that the patient may have from a wearable device, a Fitbit tracker, patient activity, weight, blood pressure, with electronic medical record information that gives us information about a patient's prior history of how they decompensated or where they were. So there are a number of companies that are working in this space, but there is no commercially available system that does that. So typically what we do when we get a heart failure alert, we call the patient and we ask for all of those things. But then again, that's a very labor intensive process. You know, you have to hope the patient picks up the phone, you know, and there's so many hurdles, you know, to making that happen. It is not easy currently to make that happen.
Okay. Maria Juliana, do you have another question? Okay.
Yeah, I have one. Do you notice any difference between the brands talking about, for example, the optimal measure? I mean, talking about the sensitivity and specificity, would you prefer to work with one of them or?
I believe that and it stands to reason that a system that involves multiple sensors and integrates that information is likely to have a better sensitivity and specificity than a system that involves a single sensor. And for the reasons Luis just mentioned. So the more information you get, I think you refine the sensor a little bit better. I don't think that an Optival alone is enough, you know, to really get to that level. It has to be combined with additional variables.
I have another comment. I mean, one very important point that we got from your talk, Dr. Mittal, is that now you have evidence to demonstrate that starting earlier, right, the remote monitoring improves outcomes compared with waiting for a 90 days period or something like that, right? So this is very important because, to be honest, we try to delay remote monitoring in our patients for logistics things. But with this evidence, obviously, we have to rethink our workflows, looking for the benefit of the patient. But could you comment deeper about what could be the reason why this is happening? Why starting earlier remote monitoring improve the outcomes when compared with delaying the monitoring remotely?
So I think that there's three possible explanations, and I think they're probably all related in some way. So the first is, of course, that maybe by starting earlier, you have an earlier opportunity to pick up issues with leads and arrhythmias and all of that. But I think that probably reflects only a part of the issue. I think the two more important variables is that the patient who gets engaged with remote monitoring earlier is probably a more sophisticated patient and is probably more likely to care for other aspects of their health better than, you know, than people who are not engaged. And the third aspect is that when a patient gets enrolled in remote monitoring earlier, that means that a physician has gotten involved, recommended that, and started that And likelihood is that that's a more sophisticated provider as well. So now if you have a better patient being cared for, a better doctor with earlier technology, and you put that all together, the patient outcome, I think, improves over time very quickly.
Yeah. Do you think that the implantation, the decision to implant could be the tip of the iceberg in those patients? Like when you see a patient with, for example, with VT and cardiopathy, you know that the VT is a marker for bad prognosis and progression of the disease. Maybe could be part of the explanation is that those patients undergoing for the first time a device implantation could be sicker, right? Could be a specific moment, a transition moment when you have to care earlier or sooner those patients. Do you think that? Maybe?
It's possible. Yeah, it's definitely possible. There's one other point that I'd like to make, and that is that, and in the United States, typically what used to happen is that a device would be implanted by me, an electrophysiologist. Then the patient would be followed by their cardiologist. And the cardiologist would say, I am perfectly capable of remotely monitoring my device, right? So they maybe have 5 patients, 10 patients, 20 patients. Another cardiologist would have 10 or 20 patients. What we found is that we don't think that remote monitoring can be done well like that. It